Hello, my name is Andrew Way and I'm a haematologist at the Walter and Eliza Hall Institute of Medical Research and also the Peter MacCallum Cancer Centre and Royal Melbourne Hospital in Melbourne, Australia. So patients can present with myelodysplastic syndrome or acute myeloid leukemia in a variety of ways. Perhaps the most frequent presentation, however, is just a patient who complains of fatigue and a routine blood test has identified an incidental cytopenia. We know that patients with mild reductions in their blood counts may have a variety of possible causes for this, and in some instances, a cause is not found. And if the patient has had some molecular testing, then this may help to distinguish between idiopathic cytopenia of undetermined significance and clonal cytopenia of undetermined significance. Obviously, a bone marrow examination is required to distinguish whether these cytopenias are either idiopathic or related to a clone but not pathologic of either myelodysplastic syndrome or acute myeloid leukemia. It's also important to get a history from the patient of any prior cytotoxic exposure because therapy-related AML, or what we call now acute myeloid leukemia with prior cytotoxic therapy, is one of the most rapidly growing subgroups of AML, comprising almost 10% of newly diagnosed patients, according to a recent Swedish study. And so we know that there's quite a lot of overlap between patients with myelodysplastic syndrome and acute myeloid leukemia, and our diagnostic investigations are critical to making this distinction. When a patient presents with symptoms or blood count reductions potentially associated with an underlying myeloid disorder, it's important to do a blood film first. And the blood film may give some indication of the presence of blast cells. Any indication of blast cells or where the cytopenia is unknown in terms of its origin should lead to the performance of a bone marrow examination. The bone marrow examination comprises two parts, the aspirate and the trophine. The aspirate obviously is helpful to enumerate the percentage of blasts, which will help in the classification of AML, and also the presence of dysplasia, which is relevant for myelodysplastic syndrome, and also the presence of ringed sideroblasts if myelodysplastic syndrome is being entertained. The bone marrow aspirate is also important for other tests such as flow cytometry, which will characterize whether the blasts are myeloid or lymphoid in origin, and also for prognostication, which includes cytogenetic and also molecular information. The molecular information is also critical for determining whether specific targeted therapies are also appropriate, and this will be discussed later. Finally, the bone marrow trophine is also important for determining whether fibrosis is present, which is obviously relevant in terms of the etiology of the myeloid disorder. What we should understand is that the myeloid disorders comprise a constellation of different overlapping hematologic conditions, and the most important ones being MDS and AML, and the potential for some overlap from a variety of different possibilities, including the number of blasts, with new classifications suggesting that patients with 10 to 19% blasts have an MDS/AML overlap syndrome, and also the possibility of molecular abnormalities, which there is also extensive overlap between various myeloid conditions. And so classification can help us to try and refine what diagnosis the patient have, but we must be aware that these classification systems are imperfect, and there are always going to be patients where they don't seem to have features which are completely distinct of one particular myeloid condition versus another. So in terms of categorization of myelodysplastic syndromes, we know that there are two new recently published classifications by the World Health Organization and also the International Consensus Classification. These define the disorders by a variety of parameters, including the proportion of blast cells in the bone marrow, with blast cells less than 5% in the bone marrow characterizing myelodysplastic syndromes of low blast levels. And these can be subcategorized into patients who have either del(5q) or SF3B1, which is most commonly associated with ringed sideroblasts. Patients with higher levels of blasts, 5 to 9% or 10 to 19%, are then classified into a variety of other myelodysplastic syndromes with higher blast levels. What I wanted to point out is that both the WHO and the ICC classifications now also allow the possibility of acute myeloid leukemia to be diagnosed in patients with less than 20% blasts. In the WHO classification, patients with AML and defining genetic abnormalities, which comprise a variety of molecular features distinctive of AML, can be categorized as AML even with blast counts under 20%. Furthermore, with the ICC classification, there is now a category of patients who are called MDS/AML, and these patients can have between 10 to 19% blasts and be considered either an MDS or an AML, depending on the clinical course and other parameters, and enabling the patient to receive either MDS or AML-based therapies, and recognizing that there is an overlap between these two conditions and not having 20% as a hard border between these two conditions. With respect to the WHO 2022 classification, there are a number of defining genetic abnormalities which will allow a diagnosis of AML to be made even with less than 20% blasts, and the most important ones being patients with PML-RAR alpha fusions, otherwise known as acute promyelocytic leukemia, and also the core binding factor abnormalities. And there are a whole variety of other conditions, including NPM1 mutation, which is not infrequently diagnosed with patients with less than 20% blasts, and is important to identify because these patients should receive AML-type therapy rather than MDS-type therapy. With the ICC classification, as I mentioned before, there are a variety of subgroups which are defined as MDS/AML conditions, and these may be associated with either P53 mutation, myelodysplasia-related gene mutations, myelodysplasia-related cytogenetic abnormalities, and in the absence of these, this condition can be called MDS/AML, not otherwise specified. And so we now need to recognize the possibility that patients with blast counts of between 10 to 19% may either have MDS or AML or an overlap scenario, and this should be considered in the treatment decision-making process. The distinction between MDS and AML is part of classification. And that's important because clearly classification is an important part of determining what the patient might have, and also for how to categorize what diagnoses we make in the hospital for registry purposes. However, it's important to recognize that classification is just one part of a number of different factors which are important for determining what the treatment is that the patient should receive. And so the MDS/AML classification enables us to consider a patient that has an excess of blasts clearly, but in terms of what treatment the patient receive, we should consider what clinical trials might be available for the patient. And having the classification of MDS/AML then enables us to consider whether it's most appropriate for the patient to receive an MDS-based trial or an AML-based trial based upon our clinical assessment rather than just because the patient has a blast count of above or below 20%. Second, the clinical course of the patient is really important. So we know there are patients who have 10% blasts who remain very stable, and if you do a bone marrow in 2 or 3 months, they still have 10% blasts. And that's quite different to a patient that has, say, 15% blasts, where 1 month ago the blast count was only 3%. So the clinical course and what's happening to the patient's blood counts, whether they're stable or rapidly declining, should also be considered in whether a more aggressive or less aggressive treatment should be considered. Drug access is also important. There are more drugs available for patients with AML at the moment than there are for MDS. And so again, this MDS/AML distinction allows the patient to be considered for a wider variety of treatment options than they would if the blast count was fixed at above or below 20%. And lastly, whether the patient is a transplant candidate. Clearly, not just whether the patient has MDS or AML, but a whole variety of other features, particularly their symptoms, their transfusion dependence or not, their suitability for transplant from an age and comorbidity point of view. These are all factors which should be considered in what the treatment ultimately receives. So, in conclusion, the final point I would like to make is that classification is just one part of the evaluation of the patient and does not in itself determine what the patient should receive. The implications for clinical practice of the classification is most relevant in terms of the treatments which are available to the patient. And so having this overlap syndrome of MDS and AML allows the patient to be considered for what might be best for that particular patient and expand the variety of treatment options rather than just being limited to patients with more than 20% blasts. And the importance of the MDS-AML overlap syndrome is that we know from a variety of studies that the prognosis of these patients is very similar to patients with AML and higher blast counts, and hence the treatments that are relevant for these patients are similar to those that we use for AML. And the other implication is that allogeneic stem cell transplant should be considered for all patients where the prognosis is felt to be indicative of a poor outcome. And so not just patients with AML, but I think these days patients with MDS should be actively considered for transplant, even upfront transplant, particularly if the condition is stable and the prognostic score either by IPSS-R or IPSS-M is high enough to indicate that a transplant is required. And so the implication of that is that we should not just consider patients with MDS for palliative and non-curative therapy, but that transplantation should be an active consideration in every patient.
Hello, my name is Professor Agnieszka Wierzbowska, and I am head of the Department of Hematology of the Medical University of Łódź, Poland. Currently, we know very well that both MDS and AML are caused by the somatic mutations that accumulate in hematopoietic stem and progenitor cells. And we also know very well that several driver gene mutations can cause clonal proliferation. However, most patients have combination of driver mutations, and usually at one set of MDS, the median number of driver mutation is 2 to 3 per patient. And there is evidence that RNA splicing and the DNA methylation mutations seem to occur as a very early event at MDS development. These mutations usually determine the clonal proliferation, the bone marrow hyperplasia, and also lead to ineffective hematopoiesis and peripheral blood cytopenia, which are very well-known features, clinical features of myelodysplastic syndromes. The enrichment of signaling gene mutations for example, like FLT3 ITD or FLT3 TKD, RAS family member mutations, is usually associated with the risk of transformation of low-risk MDS to higher-risk MDS, and also transformation of higher-risk MDS to AML. Last year, two classifications, the WHO and ICC, were published, and both systems include the MDS subtypes defined by genomic features, which are actually the same. In addition, the ICC includes also other conditions whose diagnosis requires detailed molecular profiling. For example, the clonal cytopenia of undetermined significance. But I would say that the absolutely major difference is the approach to MDS with blast percentage between 10 to 19%. In WHO classification, this entity is renamed only as MDS with increased blasts, except for excess of blasts. In ICC, this entity was moved to a totally new category, MDS-AML, to recognize and also emphasize the fact that these cases lie on the border between MDS and AML in terms of their biology, prognosis, and these cases should be eligible for either MDS and AML clinical trials or other therapeutic approaches. So just this subclassification and the subtype MDS-AML underlies the continuum of the transformation of higher risk MDS into AML. So we know that although some entities are identical between the WHO classification and ICC, but still several significant differences exist. And at the last ASH meeting, plenty abstracts addressed the validation of current diagnostic classification. And for example, the American group evaluated the outcomes in 118 MDS patients treated between 2018 and 21, which were reclassified according to WHO 2022 classification system. And the authors confirmed that defined mutational features defined in WHO classification were strongly associated with morphologically defined subgroups and also overall survival. So they confirmed that the WHO classification works. In another study, patients with newly diagnosed MDS based on WHO 2016 criteria were rediagnosed and reclassified according to WHO 2022 guidelines. And it turned out that 30 MDS patients in this group had nucleophosmin-1 mutation, which resulted in changing the diagnosis from MDS to AML, even though some of the patients had low-risk MDS earlier with less than 5% of blasts. So in the future, this diagnosis will implicate the more aggressive therapeutic approach. And right now, we don't know the long-term effect of this aggressive therapeutic approach, particularly for those patients with only few percentage of blasts. And the third analysis from the ASH, it is a big cohort of more than 2,000 patients with MDS who are reclassified according to WHO 2022 and also current ICC classification. And this analysis showed that molecularly defined entities like SF3B1, 5q deletion, or B-allelic p53 mutation are clearly unique. A blast count of 5% correlated better with outcome than the cutoff 10% of blasts. And probably it reflects better an accelerated phase in the disease biology. And of course, the final observation from the study was that MDS with multilineage dysplasia patients had significantly worse overall survival as compared to patients with single lineage dysplasia, which is in favor of ICC classification and confirms that the number of lineage involved with myelodysplasia matters. So it seems that still ideal classification do not exist. So I think that the using of both classification in clinical practice will not affect the AML diagnosis significantly. And for example, the data from the very elegant German retrospective study covering of more than 1,400 patients with MDS or AML diagnosed according WHO 16, who were classified according to current WHO and ICC classification. This data showed that less than 1% of additional AML diagnosis could be made only in WHO classification. In ICC group, about 10% of cases were upgraded from MDS to AML compared to the previous WHO classification, but it was mainly due to introduction of this new subgroup, new entity, MDS AML. So in my opinion, the introduction of MDS AML category increases, for example, chances to receive more intensive and potentially curative treatment for some MDS patients. However, I think also that it's very important for clinicians and also pathologists to be mindful of these key differences and their potential implications in the diagnosis and management of MDS and AML.
Hello, my name is Gert Ossenkoppele. I am a hematologist located in Amsterdam, working at the Amsterdam University Medical Center, and I have a special interest in acute myeloid leukemia and myelodysplastic syndromes. Well, as you know, myelodysplastic syndromes are a group of clonal hematopoietic stem cell disorders that is characterized by morphological dysplasia, ineffective hematopoiesis, and peripheral blood cytopenias, and all show a risk of progression to acute myeloid leukemia. And the disease management of MDS is really challenging due to heterogeneity in clinical courses and long-term outcomes, and therefore risk classification is really important. Risk stratification for MDS was until recently mainly based on the IPSS-R, which considers hematological parameters and cytogenetic abnormalities. And this scoring system has set for a decade a global standard for patient risk stratification, clinical trial design, correlative analysis, and treatment recommendations. However, somatic gene mutations, which we now know are really important determinants of prognosis, are not used in the IPSS-R. And in a recent developed clinical molecular prognostic model, IPSS-M, pre-treatment diagnostic samples from nearly 3,000 patients with MDS were profiled for mutations. Clinical and molecular variables were evaluated for associations with leukemia-free survival, leukemia transformation, and overall survival. And this model uses blood counts, marrowblasts, the 5 IPSS-R cytogenetic categories, while 16 main effect genes and 15 residual genes came out as important from the analysis of 152 tested genes. TP53 mutations, FLT3 mutations, and MLL-PTD were strong predictors of adverse outcomes, highlighting the importance of screening for those mutations at diagnosis. And not all SF3B1 mutations were associated with favorable outcomes. Unfavorable subsets could be distinguished on the basis of co-mutations. And using these parameters, the IPSS-M resulted in a unique risk score for individual patients. Ultimately, 6 IPSS-M risk categories with prognostic differences could be distinguished, varying from very low to very high. The IPSS-M score is personalized. It's a continuous score with a virtually unique value per patient. It's interpretable. A 1 unit increase in score results in a doubled risk. It's reproducible and provides a flexible and also a strategy to account for missing values. And from the continuous IPSS-M's risk score, a discrete 6-category scheme is built, which will guide eligibility criteria for clinical trials and interpretation of correlative study results. Molecular testing is not yet routinely globally because of cost, infrastructure, and reimbursement considerations. And the IPSS-M provides a focused list of 31 genes that can be prioritized as centers set up their routine diagnostic pipelines. And in the meantime, the ability of the IPSS-M to handle missing data allows for the score to be applied in diagnostic settings that do not capture the complete list of genes in the model. And importantly, a patient's IPSS-M score can be calculated using the IPSS-M web calculator. Well, compared with the IPSS-R, the IPSS-M resulted in improved prognostic accuracy across all long-term clinical endpoints: overall survival, leukemia-free survival, AML transformation. It can not only be applied for primary MDS, but is also applicable in secondary and therapy-related MDS. In the original study, in which the IPSS-M module was developed, comparison with the IPSS-R showed that the IPSS-M improved prognostic discrimination across all clinical endpoints and restratified 46% of patients. And at the latest ASH 2022, a number of studies were presented comparing IPSS-R with IPSS-M, and all showing that around 40 to 45% of MDS cases were restratified. And these data were from single center studies, clinical trials, and also real-world data. So in the majority, the classifications was upgraded. Clinical consequences for treatment are highest when low-risk patients are reclassified as high-risk patients, but also downgrading from high to low risk is important in terms of treatment decision-making. And in one study presented at the ASH 2022 by Georgi, showed that 70% of restratifications had a potential impact on therapeutic choices. So it's completely clear that with the introduction of the IPSS-M, we get an improvement in stratification of MDS patients. Well, a couple of updates of new classification appeared in very recently. For example, an international consensus classification of acute myeloid leukemia discussed by an expert panel hematologist was recently proposed, introducing a number of changes. And these changes were that the blast thresholds defining AML were changed. So AML with recurrent genetic abnormalities requires now more than 10% blast instead of 20% blast. And also a new diagnostic entity was introduced called the MDS AML. And that is used for cases with 10 to 90% blast. And these were previously characterized as MDS EB2. And also a number of new genetically defined entities were introduced. For example, the AML with the mutated TP53, AML with myelodysplasia-related gene mutations, which are highly associated with secondary AML evolving from an antecedent hematologic neoplasm, and also AML with myelodysplastic-related cytogenetic abnormalities was among them. And this ICC was at the basis of the risk classification by ELN 2022 that was updated from the 2017 classification. And it's good to realize that the ELN 2022 AML risk classification is based on data from intensively treated patients and may need modifications for less intensive therapies. And also important to appreciate that initial risk assignment may change during the treatment course based on minimal residual disease analysis. So the major changes that were introduced in the update of the ELN classification were that all AMLs with a FLT3 ITD are now categorized as intermediate risk, regardless of allelic ratio and NPM1 mutation status. And this was done because there were methodological issues with standardizing the FLT3 ITD allelic ratio. Also, the role of MRD for mutant NPM1 plays an important role, and the impact of the FLT3 inhibitor-based therapy on FLT3 ITD AML changed the prognosis for those patients. And another change was that AML with myelodysplasia-related gene mutations are now in the adverse risk group. And these mutations include, for example, the ASXL1 and the B-core and EZH2 and so on. And previously, in the previous classification, the biallelic CBP alpha was classified as an favorable acute myeloid leukemia. And this has now changed by the lysine zipper region of CBP alpha, and that is now classified in the favorable risk group, irrespective of biallelic or monoallelic mutations. And an important change is also one that says that the presence of adverse risk cytogenetic abnormalities in NPM1 mutated AML are now classified as adverse risk. So really a lot of changes in these new updates of the ELN classification. Well, I think the most crucial question for initiating treatment in acute myeloid leukemia is whether a patient classifies for intensive treatment. Once decided for intensive chemotherapy, then the ICC and the ELN classification are important for treatment decisions. And the new classification upgraded or downgraded AML patients, which obviously has consequences for treatment choices. The introduction of the MDS AML subgroups can also lead to AML treatment and inclusion in innovative trials. And the molecular profiling that is on the basis of the new classification has become extremely important. TP53 mutated AML should be induced with 3+7 can be discussed, given the very bad outcomes even after allogeneic stem cell transplantation in complete remission. We are waiting really for new, more effective treatments in this bad disease. And then the introduction of MRD in risk profiling can also be helpful in informing to transplant or not to transplant, and also for the choice of the conditioning regimen and post-transplant and maintenance strategy. So really the new classification has impact on the treatment of our acute myeloid leukemias, in which the prognosis during the last 10 years has improved enormously.